This video presentation is about shoulder pain, how to make the diagnosis. I am Mary Lloyd Ireland with the Department of Orthopedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. The key in making any patient happy and solving or curing their musculoskeletal problems is to make the primary diagnosis. So we as orthopedic surgeons, primary care physicians, need to listen to patients, know how to examine patients, and make the primary diagnosis. Imaging certainly helps in the shoulder. Think about doing plain films, routine views, and imaging if they don't get better. I hope this presentation has helped you be a better diagnostician and a clinician examining the joint of the shoulder. The shoulder pain algorithm that we talked about should give us a pathway for treating patients with shoulder pain. The special imaging MRI scan with or without gadolinium. I usually will do intra-articular gadolinium or order this if I'm thinking of a slap tear. Otherwise, for rotator cuff tears, we don't need intra-articular gadolinium. Scans are improving. We can see tendon problems without the gadolinium. Other special studies, you can do a abducted external rotated view of the shoulder with an MRI scan. You may see a peel back of the labrum, so that may diagnose a labrum tear. CT scans more for bony injuries or fractures, or if you're looking at somebody who has significant anterior instability, you want to assess how big the Hill-Sachs lesion is or what the size of the Bankart lesion is to figure out if you're going to need to do some bone augmentation procedures. Ultrasound is gaining in popularity more for supraspinatus tears, more for fluid around the biceps, and also for injections if there's a problem locating where exactly you want to put the injection, into what tendon or what space or joint. Ultrasound is accurate. It's a lower cost than MRI scan. It can be done in the office. And I think this will be something that more and more physicians are trained in doing ultrasound. More radiologists, as also more primary care physician and orthopedist, both as a diagnostic and a therapeutic maneuver to be able to treat the tendinopathies about the shoulder, the partial tears, and even to perhaps do some biceps tenotomies with ultrasound guidance. I refer you to this Journal of the American Academy of Orthopedic Surgeons article regarding rotator cuff ultrasound diagnostic capabilities. This is an ultrasound showing a previous This is an ultrasound showing progression of a previously asymptomatic rotator cuff tear, 1991 on the left and 1997 on the right. So we can also follow the size of the cuff tear, which is very important when you get it on some of these massive cuff tears that are not repairable, to have counseled patients if they're having a significant progression in size of the cuff tear. Shoulder pain algorithm. Differential diagnosis categories are rotator cuff disorders, a frozen shoulder adhesive capsulitis, which we see most commonly in the perimenopausal female, glenohumeral instability, very common in the younger individual, contact as well as multidirectional instability, arthrosis in the older individual or with a massive rotator cuff tear with rotator cuff arthropathy, AC disorder, more related to the shoulder who is in a weightlifter, and fibromyalgia, rheumatologic problems. So these are our differential diagnostic categories. So in this algorithm, needs specialized care, refer to a specialist, get a consult, Definition of a musculoskeletal specialist: it's a licensed physician who focuses on management of musculoskeletal conditions. It's going to be a sports medicine, fellowship trained primary care physician, orthopedist, physical medicine rehabilitation. But the bottom line is refer them, get the consult before doing a workup that may not be necessary. In conclusion, working up a shoulder pain patient, don't order a test if you can't read it. Communicate with a radiologist at your imaging center. Go over the scan. A bad scan is worse than no scan. In the state of Kentucky, we have many MRI scanners. Shoulder scans are notoriously bad if ordered by someone who is unable to examine a shoulder. So when we're faced with a patient we're now seeing in consultation with a bad MRI scan, we have to discuss whether or not we need to get yet another study or treat what their symptoms are or operate on them. So in my opinion, a bad scan is much worse than no scan, and an early consultation is the best counsel. Send them to somebody that knows what they're doing. Sometimes an MRI report just doesn't help. This is a Chinese soccer athlete whose knee underwent an MRI scan. You can see that it says Lockman in there. I can't read anything else, but sometimes the radiologist reading is very difficult to interpret, and patients have copies of their reading, and we spend a lot of time as orthopedic surgeons describing why the radiologist read this and the fact that it may not correlate with their symptoms. So a lot of things are overread with MRI scans of the shoulder, and you need to focus on what the primary problem is. Apologies to the radiologists, many of whom are great. Conclusions: knowing anatomy, understanding biomechanics, the sport of injury, and mechanisms, we can make a diagnosis. The physical exam and the specific diagnosis are made. Physical exam makes sense if you know the anatomy and the sport, and then you can make a specific diagnosis by history, physical, and good plain radiographs. Remember in pitching, that little leaguer, 8 to 10-year-old who comes in thinking they're going to be like a pro player. Remember, little league pitchers do not become big league pitchers. And Nolan Ryan didn't start pitching until he was in high school. So imaging that young shoulder, get plain films. Most likely in an 8-year-old it's going to be a proximal humerus fracture and not a rotator cuff tear. However, we're seeing more and more younger pitchers have injuries, as we showed during this production of a slap tear and a rotator cuff tear in a high schooler. So try to put the whole picture together. Think about the neck, the back, the scapula, and the shoulder, and treat the entire patient. In that picture, he could be in a growth phase. He could have weakness of his opposite hip, so you want to examine the entire patient to make the diagnosis. There can certainly be referred pain from the neck, tumors. So remember that you may not have seen it, but it has seen you. Thank you very much for your attention. I hope you are a better examiner of the shoulder